Hello. Thank you so much for joining us for this exclusive screening of Spark. We hope you all enjoyed this and that it was educational and we all learned something. My name is Dr. Samantha Holden. I am an assistant professor of neurology here at the University of Colorado. I am trained in both movement disorders as well as behavioral neurology. So my clinical practice as well as my research really do focus on that overlap of conditions where there are changes in movement as well as in thinking, memory, and behavior. I am so pleased to be joined today by two of my colleagues, Dr. Karina Drake, who is a geriatric psychiatrist here at the University of Colorado as well as Dr. Evan Pliss, a geriatric psychologist. And to discuss some of the themes that came up from the video today, hearing more about the insider's view of Robin's story, I'm so happy to have this degree of expertise on the panel with us today to cover some of your great questions, some of which came through on our registration page and some that have come up as the film progressed today. So with no further ado, let's dive in. One of the common questions that did come up through the registration primarily, given the current environment we're all living in, the fact that we're all virtual today and seeing each other through this Zoom setting rather than in person, is COVID vaccine safe for people with Lewy body dementia? Yes, please get vaccinated. Everybody please get vaccinated. The risks of developing COVID-19 are much greater than any risks of the vaccine itself. I have been in clinic and seeing a lot of my patients with Lewy body dementia, many of whom have been vaccinated, and almost everybody has done extremely well with the vaccine and now has that weight off their shoulders where they don't have to worry about developing severe disease requiring hospitalization or death from COVID. So please get your COVID vaccine. Moving on to some of the other questions. A really good one that we cover a lot in clinic with our patients and with our family members is, how is Lewy body different from Alzheimer's? And how is that different from the memory changes that just come with old age? I covered that a little bit in the primer before the movie started, but there are a lot of overlaps in these conditions. And the way that we try to separate it out when we're meeting somebody in the clinic are with a few different clues. With Lewy body specifically, the things that I'm going to be asking people and their loved ones about are a few of those diagnostic criteria, the clues that are more specific for Lewy body as opposed to Alzheimer's, which is the acting out of dreams, the REM behavior disorder, which can occur years before any of the other symptoms come up. That is a very important clue for me in trying to understand what's going on inside of somebody's brain, is the acting out of dreams. And now a lot of people do strange things in their sleep that is not necessarily REM behavior disorder. So if there's any question, getting that sleep study and seeing exactly what's happening in somebody's sleep can be very informative. And don't worry, some people say, well, what if I don't have a dream that night? What if I don't act out that dream? Is it a wasted night? No, there's changes that we'll see in the muscles of the body while you're in REM sleep, that phase of sleep when we dream, when the body should be completely paralyzed. So even if you don't have a vivid dream or acted out that night, we will still be able to diagnose that condition. So the REM behavior disorder is a really important clue. The presence of hallucinations and delusions that we're going to talk a lot about today with Dr. Drake and Dr. Pliss is also informative for us. While psychosis is not specific for Lewy body, we can see it in any of the dementias. It's usually much more frequent or prevalent in people with Lewy body. And as we'll also talk about, they're somewhat stereotyped. The people and small animals seems to be pretty specific for Lewy body. The pattern of thinking and memory changes in Lewy body is also a little bit different from what we see in Alzheimer's, where Alzheimer's is much more memory predominant, short-term memory especially. And while people with Lewy body can be somewhat forgetful, there's a lot more change in what's called executive functioning, planning, multitasking, making decisions, shifting attention between different tasks, following multiple steps of a command. Those things, which may seem more like memory to some people, it's actually more specifically executive function. So trying to figure out exactly what somebody means when they say, my memory is bad, or when a loved one says we're worried about their memory, trying to sort out exactly what we mean by that can also be helpful. The thing is, there is an incredible amount of overlap between Alzheimer's and Lewy body, where the older we are, the higher the risk of developing several different types of pathology in the brain. For people who clinically have dementia with Lewy bodies, the Parkinsonism, the hallucinations, the REM behavior disorder, and fluctuations, if they were to pass away and have an autopsy, there's an up to 80% chance that there's also the Alzheimer's plaques and tangles inside their brain, in addition to the Lewy bodies. Vice versa, for somebody that clinically has Alzheimer's, with mostly short-term memory loss, trouble with orientation, there's up to a 50% chance that they also have Lewy bodies in their brain. So we diagnose the condition in life based on the symptoms, what fits best, making sure we rule out anything else, especially anything that could be treatable or curable, but making our best educated guess with the information that we have available to put somebody in the right category so that they can get the right treatment, so they can be put into the right clinical trials. But still, for all of these conditions, the only 100% diagnosis is pathology, a little piece of the brain under a microscope, as unfortunately we saw in Robin Williams' case. For the memory changes that occur just with aging, we're still trying to sort out what exactly normal is, and most neurologists will tell you there's no such thing as normal, as will our colleagues in psychiatry and psychology. It's all shades of gray, but what is common versus what is uncommon is probably a better way to frame it. There are certainly things that change as we get older, slowed processing speed, a little bit of short-term memory loss, but there are those people that make it to 100 sharp as a tack. So what's special about them? But trying to separate out what's just normal for my age versus what's the earliest signs of something to worry about, that's our job. And that's why we want people to come into our clinic as soon as possible so that we can get a very detailed, thorough evaluation and figure out what's something we can keep an eye on versus what's something we need to intervene on. So I mentioned the psychosis symptoms, and psychosis is a word that's also stigmatized and has been used incorrectly. All it means is the presence of hallucinations, whether that's visual, auditory, hearing things, tactile, feeling things, olfactory, smelling things, and delusions, which are false fixed beliefs. People can have varying degrees of insight into these hallucinations or delusions. Some people recognize that they're not real. Sometimes there's a little bit of uncertainty if it's real or not. And then sometimes people lose insight completely and cannot be convinced otherwise. This is one of those core features of Lewy body, specifically well-formed visual hallucinations. Hallucinations in any other modality, whether it's hearing or feeling, are supportive, but not indicative of Lewy body, as are the delusions, which can be paranoid or persecutory, or delusions of doubles. So sometimes thinking that a loved one has been duplicated, or that a loved one is somebody else in disguise, or that the whole house has been duplicated. I don't want to go back to our other house. I know this looks exactly like our house, but I want to go to the other house. So those are common delusions that are supportive, but not necessarily in the core criteria as the visual hallucinations. So I want to throw this over to our colleagues, Dr. Drake and Dr. Bliss, to talk a little bit more about how do we interact with people who are experiencing these hallucinations or delusions. How can we make sure we are keeping track of our loved ones to make sure that they aren't dealing with this alone, as Robin was? What are the things we can do to prevent it and to treat it appropriately?
Thank you so much, Dr. Holden, for that introduction. And also, giving some background information in terms of the most common hallucinations that we see with Lewy body. Just to summarize, typically, it's most common that people have these well-formed visual hallucinations. So seeing faces, people, animals, but in other cases, there can also be auditory hallucinations or the delusions that Dr. Holden mentioned. And so in thinking about treatment of hallucinations and delusions, I think one of the important first things to think about is if there's ever very sudden onset of these symptoms, that they come on in a very, very brief period of time, or there's a really significant change, I think it's also always important to consider the potential for medical issues. So if these symptoms arise, certainly seeking out medical treatment, because patients who have Lewy body dementia, and let's say, for instance, they also develop an infection or a metabolic derangement, they can be much more at risk of having some of these psychotic symptoms as a result of medical illness. So I think that's always, for me, the first step is to make sure that there's no other co-occurring medical issue that requires treatment. So once that's been ruled out, there are also excellent treatment options in terms of managing these symptoms. The first class of medications that I think about and also recommend to patients are the cholinesterase inhibitors. So these are medications that have indications in a number of different types of dementia. And they can have some benefit, or they do have some benefit in terms of helping with cognition. And specifically in Lewy body dementia, they can often also decrease the intensity of visual hallucinations. And since patients often can have a range of symptoms, sometimes mild visual hallucinations that respond to cholinesterase inhibitors, versus on the opposite end, sometimes patients can have more severe symptoms where they're having visual hallucinations that maybe don't respond to first-line treatment, or they're having other upsetting or disturbing auditory hallucinations or delusions. That's when we think about potentially trying other medications like antipsychotics, which can reduce the intensity of these symptoms, but it can be a balance because these medications can also worsen movement side effects and other common physical symptoms that go along with Lewy body. So that's where it's really important that these medications are prescribed in conjunction, seeing a neurologist, as well as, depending on the severity, a psychiatrist. And so there can be a balance between managing hallucinations while also closely monitoring for any new physical symptoms or side effects that come up. The other type of medication I will bring up is a couple of years ago, there was a new antipsychotic medication that was released that's specifically indicated for the treatment of psychosis in Parkinson's. And so it also has some, crossover with Lewy body, and that's called pimavanserin. And so this is a medication that can help reduce the hallucinations without causing some of the intolerable side effects. So, depending on the type of symptoms, the severity and duration, there's a host of treatment options that are available for individuals experiencing these types of symptoms.
How about things we could do without medications?
That's a great question. I think that's always one of the other, really important things. Are there some types of, behavioral interventions or environmental things? Like, for instance, sometimes as a result of, somebody having auditory hallucinations coming from Lewy body, that may be an environmental cue, right? They're hearing conversations at night of other people, talking, like, especially if they're in assisted care. And so, a kind of a quieter environment. I think also exploring potential distraction techniques. Could there be something, like listening to music, or like when these hallucinations come up, other potential ways to mitigate some of the distress. And then also the same with visual hallucinations. I think understanding, are there specific environmental triggers? Are there ways to kind of mitigate those triggers when they come up, just to reduce the frequency of having these hallucinations emerge?
And I'm monitoring the Q&A as we're talking as well. And someone very astutely pointed out, kind of bringing up the issue of the black box warning on antipsychotics for use in older people, especially older people with cognitive impairment. Do you want to comment on that as well, Dr. Drake?
Absolutely. And that is a really, really excellent point that I always consider when thinking about antipsychotics in patients with dementia. And so the black box warning, or the risk, is that there is a small but significant increase in all-cause mortality in dementia patients taking an antipsychotic. So whether that be, cardiac event, strokes, so there are very potential significant risks with these medicines. And so oftentimes when I'm treating a patient with Lewy body, it comes down to a risk-benefit analysis. I think that there are certainly cases where the hallucinations and delusions can cause a lot of distress and can be life-threatening in and of themselves, especially if individuals are scared or engaging in concerning behavior as a result of the symptoms. And a lot of times the psychotic symptoms also really dramatically impair people's quality of life. And studies have also shown ability to stay in their home. That can be another big factor, that it can be very, very challenging, of course, for families to deal with these type of symptoms. So I think it's really an individual risk assessment depending on the severity. So it's certainly extremely important to consider the black box warning, and then also having a frank discussion with patients and their families about what the benefit and risks might be. And at the same time, since often hallucinations can be for a limited time period, depending on the stage of dementia, I think it's always extremely important to assess the efficacy. So having like regular follow-up visits to see, is this medication having the intended effect? And then also starting the lowest dose possible that controls symptoms, and being very aware of when that phase, when maybe the hallucinations are starting to lessen, assessing, do we need these antipsychotic medications on board, especially because we know the long-term potential risks.
Absolutely. Yes, there's certainly a tendency to keep adding medications and not necessarily thinking about what are these actually doing? Is there anything we can get rid of? So always reassessing, looking at that list, making sure it's not ever increasing, and what can we get rid of? Because some things aren't even necessary after a while, and then some things may be harmful even if you've tolerated them for a while. So absolutely, really good points there. Great. Moving on to some of the other great questions. There were quite a few questions about the genetics of Lewy body dementia, and if it's in any way hereditary, if somebody is affected, what does that mean for their family members, especially children or siblings? This is a really hot topic right now. For a long time, we didn't have a lot of evidence to go on in terms of counseling people about the genetics of Parkinson's or of the Lewy body dementias. But more recently, some new research is coming out, including a hot off the press research study by Dr. Sonia Scholes, who's at the National Institute of Neurological Diseases and Stroke, where they have run an enormous study of many, many different people with Lewy body dementias, looking at their genetics and seeing if anything seems to be popping up. Are there any common threads that seem to be bringing together these different people with the same condition? And Dr. Scholz's paper was just published, and they found 5 specific genes that do seem to be more commonly changed in people with Lewy body dementias. Importantly, not necessarily that these genes cause the Lewy body dementia, but instead they are involved in its pathogenesis, how the disease comes about, and can increase the risk of developing it. So in terms of the genetics of diseases overall, everything's genetic, everything about us comes from our genes. But in most cases, our genes are not sufficient on their own to cause a disease. Something needs to activate those genes, whether it's something in our body otherwise, exposures, our environment, bad luck, that something has to come from those genes to cause the disease. Now, there are some strongly inherited neurological diseases, of course, where if mom or dad had it and you have a 50-50 shot of getting it from them, that's incredibly rare. And we don't know of a lot of genes like that in Lewy body. But of those 5 genes that Dr. Scholz's study discovered in her paper, one of them is ApoE4, which is a known risk factor for the development of Alzheimer's disease. Again, it doesn't cause Alzheimer's disease, but it can increase the risk of somebody with the specific ApoE4 allele developing Alzheimer's. So ApoE4 also seems to be playing a role in Lewy body. Another gene called glucocerebrosidase, which is in young children, if somebody has a mutation in both of their copies of that gene, can cause a metabolic disorder called Gaucher's disease. It's more common in people of Ashkenazi Jewish descent, but it is in the general population otherwise too. And that having that gene increases the risk of both Parkinson's and the Lewy body dementias. There's another gene, SCNA, which codes for the alpha-synuclein, which is that protein that gets sticky and gets stuck inside of those Lewy bodies inside of the brain. And then two other genes that we hadn't connected to Parkinson's or Lewy body before. So this is just kind of a foray, a beginning of a huge genetic investigation into these causes. Right now, it seems like there are some risk factor genes that could be inherited, but no disease causing genes. So if a first degree relative has one of these conditions, it may increase the risk for that person a bit, but it's not going to be dominantly or strongly inherited in the vast, vast majority of cases. And questions about the gene testing. You know, a lot of people are starting to get direct-to-consumer genetic testing with 23andMe and things like that, and some of these genes are tested there. We often don't test for genes in our clinic unless people are very young in their onset. Young for us is usually younger than 50 years old or so, or if there is a very strong family history with multiple family members in multiple generations. But because we don't really know what the genetic information means yet, and hopefully, you know, as Dr. Leverin said in the movie, that we will develop very specific personalized care for people based on their genetics and their specific story moving forward, but I don't think the science is there yet. Okay, moving on. So obviously with, you know, the unfortunate ending of Robin Williams' story, and his death by suicide, that obviously brings up a lot of sensitive and uncomfortable thoughts and questions about the risk of suicide for people living with Lewy or living with any kind of dementia. And how do we address this? How do we keep our loved ones safe? What are the warning signs to look out for? How do we act upon those warning signs to keep our loved ones safe? So I really like to hear from our panel about what kinds of things we should be looking out for, what are some warning signs, and how to keep loved ones safe. And then also more broadly, do we know about the risk of death by suicide in Lewy body or in dementia overall?
Yeah, thanks, Dr. Holden. Also, thank you for making space for this topic. I recognize that it's really difficult to talk about and we don't talk about it. And so sometimes we don't have the right language to even bring it up. So I just appreciate, you know, having this space in this forum to talk about this really serious topic in the context of living with dementia. And we don't have great data right now about risk within Lewy body dementia. But more broadly in people living with dementia, there has been some research that does show an increased risk for death by suicide when compared to age-matched adults without cognitive impairment. So there is a bit of an increased risk, and there's a lot of different potential contributors to that, both medically and also environmentally and behaviorally. I want to highlight a couple of risk factors, though, in that population. So the first is that depression. You know, usually when we see risk for suicide and suicidal ideation, oftentimes it's in the context of dementia and depression. And so having those types of emotional symptoms actually increases the risk of suicide by 2. So it doubles that risk. The other thing is we see more risk for death by suicide earlier on in the disease process. And particularly right around the time of diagnosis. So really those early stages and that, you know, first kind of, you know, coming to terms with this diagnosis is when people, particularly who have comorbid depression, are at pretty high risk. And I think that's related to, you know, this sense of hopelessness and perceived sense of burden, you know, about what will my future look like. And so, you know, a few things to consider. First is that depression, particularly in those early stages, when we see an increased risk, is very treatable in the context of living with dementia. both by medication and by psychotherapy, and a mixture of the two is even better. So if you're experiencing those symptoms, it's really important to seek help from a mental health provider. The other thing is I think just talking around that diagnosis, talking with the family, planning for the future, having those advanced directives, and seeking social support as a roadmap for what the future holds. I think in the movie they talked about just the stigma of dementia and this, kind of collective worry and fear that we have around this diagnosis. And I think that, that really shapes how we view our future and the diagnosis, and oftentimes in an unrealistic way. And oftentimes in an unrealistic way where we expect things to be worse than they actually are. So I think having those conversations, talking about burden, talking about, this perceived sense of burden, and coming up with a roadmap as a family is really important. And the other thing is if a loved one or you are experiencing any types of those risks, like a new diagnosis on top of depression, anxiety, it's really important to do an environmental scan for safety risks. So there was consistently in research, they show that firearms are actually the most common method of death by suicide, even in people living with dementia. Some studies have reported up to 75% of deaths by suicide are related to firearms. So, making sure that, looking in the environment and making sure if someone is at risk, that there aren't those things that could be used for self-harm readily available. And that means either locking them up or having a conversation about, maybe now isn't the right time, maybe to keep you safe, we need to think about, moving these out of the environment. And I do want to, for anyone who is worried about either themselves or a loved one, there are a lot of resources that are free and both local and national as far as suicide prevention hotlines to call. One number that I would encourage everyone to take down is 1-800-273-TALK. And that's the National Suicide Prevention Hotline. And again, that's 1-800-273-TALK. And I've worked with clients who write that number down or write down their local hotline number and just put it on a sticky note next to their bed or a place where they know they might have these thoughts and might be alone and they might escalate. And just having that nearby and having that accessible, and being able to access those supports and to talk to others about that. I mean, I think that, we're talking about stigmatized topics. And so, by, making this, again, a we problem in the family, I often talk with families about that. This is often a we diagnosis. And so the same is true with comorbid mental health concerns and making sure that, again, in the environment, we have those supports accessible and that, the family is also aware of that and can support the individual, because, the last thing you want is someone to suffer in silence, even in, when they're around other people.
Absolutely, yeah. And I think it also, brings up the importance, not only the sensitivity of the topic, but the language around the topic, right? Where, even in the movie, I think, and when it was on the news that it was announced, that Robin had died, and the language of committed suicide. Do you want to talk about that at all, Dr. Pliss?
Yeah, and language is always changing and making sure that it's person-centered language and also death by suicide versus committed suicide. I think that nobody's going to, or not nobody, but oftentimes we struggle to find words around these sensitive topics because we didn't have in school, we didn't have the module about how to talk about suicide or to talk about even mental illness. And I think that's changing a bit. There is a narrative, and I definitely see some, public advertisements around suicide prevention hotlines. But I think that you will see that come up where it's kind of like a them problem, or like a shunning is kind of like the subtext in a lot of the language that we use. And I think that that's something to pay attention to, because that does set up a barrier around just creating these conversations, and also allowing yourself to make mistakes or stumble over words when you're having these conversations, because it is uncomfortable. You don't have a roadmap. A lot of families won't have experience ever talking about these topics before, and so giving yourself a break that, yeah, this is hard to talk about, and we're going to go through this together. And the reason it's hard to talk about isn't because of any dysfunction in our family or relationship or in me. It's because none of us really have gotten great training, other than the select few that have gone to grad school for 10 years to be able to stumble through this conversation.
Yeah, no, it's hard, for everybody, but that openness, right? The communication, and of just making sure you're meeting people where they're at, and doing it with love and kindness. Absolutely. And I think it also brings up, which has also come up in the Q&A here, of medical aid in dying, and how that kind of segues from these talks of suicide, where, if someone is diagnosed with an incurable, incurable, fatal, progressive condition, and the application of medical aid in dying in those situations. So we're in Colorado. I know not all of our viewers are, but in Colorado, medical aid in dying is legal, with very specific regulations around it, that somebody must have a life expectancy of less than 6 months, and that the person fully retains capacity to make the decision to end their life at the time they end their life, which inherently excludes anybody with a dementia, where at the end stages, if you're 6 months from the terminal stage of the condition, you're not going to have capacity to make that decision. So there are certainly a lot of ethical issues around this. What if somebody had clearly delineated their wishes and their advanced care planning, that when they got to that stage, they would want to participate in medical aid in dying? We can't do that right now. And there's certainly arguments on both sides, but I think something that needs to continue to be an open conversation, especially with the advanced care planning, with the people who know and love you best, so everybody's on the same page in terms of your care when you're not able maybe to participate in those conversations yourself. But then there are studies that look at people's quality of life, even when they're in late stages of incurable neurological conditions, and that their quality of life is good, and that things can change based on where you're at in life. Or studies of people who have locked-in syndrome, who are completely paralyzed other than moving their eyes up and down, that they say they have a good quality of life and would not want to end their life. So it is all relative, and how we feel about our lives and the quality therein can change depending on different situations. But I think it's a really important question that we need to continue to tackle, as a community, and taking care of one another, are these types of questions of autonomy in medical care. Okay, so we're nearing the end of our time together. There have been so many great questions. I wish we could keep going, but one question I do want to make sure we cover, because I answer this in almost every single community talk that I give about thinking and memory changes, is what can we do now to keep our brains as healthy as possible for as long as possible, whether we have some thinking and memory trouble or not. And the number 1, 2, and 3 thing that you can do for your brain, anybody that's watching, is exercise, aerobic exercise. It has the best data behind it right now. It's the closest thing we have to a cure-all. If I could bottle up exercise and give it to you in a pill, you'd be begging me for it. So exercise, anything that gets your heart rate up, works up a sweat, where you can hold a conversation, but you'd rather not. That's a moderate intensity of exercise, and a brisk walk is perfect. There's more evidence for a Mediterranean style diet, which is basically as unprocessed and unpackaged as possible, as close to how it came from the earth as you can get it. Make sure you use your brain. There's nothing special about crossword puzzles. If you like crossword puzzles, sure, but anything that keeps your brain engaged and stimulated, especially if it's fun. So don't force yourself to do homework if it's boring and you hate it. Find something fun and new to learn. Stay social. I know that's very difficult right now where we're all quarantined and only seeing each other through Zoom screens, but try to stay as social and as engaged as you can with other people, including outside your immediate circle of just your nuclear family. So friends, extended family, groups, as social as you can be, and stay safe. Getting good sleep and managing stress and making sure any mood symptoms are well managed and treated. And those 6 pillars of brain health are the best thing that we have right now to prevent and slow the progression of dementia. And up to 1/3 of cases of dementia could be prevented with those really intense lifestyle modifications. So while we're still working, while we're trying to research and learn more about Lewy body dementia so that we can have that cure in the future, take good care of yourselves and take good care of your brains. Thank you so much for joining us this afternoon for this great session of this wonderful video Spark, as well as our wonderful panel. Thank you so much, Dr. Drake and Dr. Pliss, for joining me and covering some really tough topics, but I hope that our audience has benefited and enjoyed it talking with us today. Everybody stay safe, have a great weekend, take care.